Introduction has already been taken, but central serous retinopathy is basically a fluid collection or a neurosensory retina detachment at the posterior pole, and it's self-limiting, and patients usually have a good prognosis. The acute CSCR is a self-limiting disease that resolves spontaneously in about 3 to 6 months, and you can either have a smokestack or an ink blot leak, and the leaks can be either subfoveal or extrafoveal. The indications for thermal laser treatment, which was the conventional treatment till some years back, was the persistence of fluid or serous detachment beyond 3 to 4 months, the disease recurring in the eye with visual deficits from previous episodes, a permanent visual deficit is present from previous episodes in the fellow eye, chronic signs, and occupational or other patient needs or patient requirement that requires a prompt restoration of vision and stereopsis. These are the guidelines that were suggested by GAS, that is, allows 4 months for spontaneous resolution if the first episode, wait for 6 months or longer before a photocoagulation, allow 1 month for spontaneous resolution in patients with a history of several episodes of detachment in the same eye, and when the leak is at least 1/4 this diameter from the center of the fovea, prompt photocoagulation is justified in the following cases, like detachment presents for 4 months or longer, evidence of permanent loss of acuity or visual field in either eye, secondary to previous episodes, or for occupational reasons, the patient cannot work because of visual dysfunction. The mechanism of action of conventional treatment is not well understood, but it suggests that it photocoagulates the RPE cells at the site of leakage, forming a fibrotic scarf, preventing further focal leakage. So conventional treatment is an FFA-guided laser to the exact point of leakage detected in the early frames. The spot size should be 100 microns with an area centralis lens. The power and the duration is titrated via a continuous wave test burn in the nasal mid-periphery, and the intensity of the grade burn should be a faint, just visible burn. Coming to chronic CSR is characterized by a persistence of serous detachment of the neurosensory retina and the RPE detachment for more than 6 months duration. The symptomatology includes micropsia, metamorphopsia, reduced contrast sensitivity, altered color perception, along with a varying degree of visual acuity reduction. Severe visual loss occurs in about 5 to 10% of the patients with chronic CSR, with persistent subretinal exudation, extensive RPE atrophy, cystoid macular edema and degeneration, and choroidal neovascular membrane formation. ICG angiography has shown to be the reason being an inner choroidal disease for CSR, and currently there is no standard treatment for chronic CSR. Standard PDT with vertiporphin injection has been successfully tried in chronic CSR, but however complications like RPE atrophy, choriocapillary ischemia and secondary CNVM has been reported with conventional PDT. In addition, chronic CSR, you have foveal atrophy. Functional improvement has been documented without significant retinal or choroidal damage by reducing the fluence rate of PDT. Coming to the mechanism action of PDT, it can either be a short-term choriocapillary perfusion, or it can be a cytotoxicity to the vascular endothelium, this leading on to a platelet aggregation and thrombus formation and vascular occlusion. Or it can be a long-term vascular remodeling, thereby reducing the choroidal hyperpermeability. The conventional PDT, the parameters are, it's a diode laser, wavelength of 689 nanometers. Vertiporphin is the porphyrin derivative injection that is injected at a dose of 6 milligram per meter square of body surface area. Infusion is for 10 minutes, laser is given at 15 minutes, and the duration of the laser exposure is 83 seconds, and the energy is 50 joules per centimeter square. This is the conventional parameters that is followed for AMD CNVM cases. This is the procedure of PDT. So that's the injection being given of vertiporphin, which is the green molecules that are seen. It passes through the bloodstream, and it's a lipophilic, so it gets attached to the lipoprotein molecules, which transmit the viscidine to the area of interest. For us, it's the choroidal vasculature. And once it reaches the choroidal circulation, the molecules get attached to the endothelium of the choroidal vasculature. And once it gets attached, it stays, and then it induces a damage to the vascular endothelium. So this is from the outer through the photoreceptors and the iris, and the laser will be done. And once the laser is done, the molecules are stimulated, the viscidine molecules are stimulated, releasing the superoxide molecules. And this is the choriocapillary layer, and once the laser, the viscidine molecules are stimulated, which induces the clotting cascade. Once the clotting cascade is stimulated, then you get thrombus formation with the release of platelets and macrophages, and then the ultimate closure of the vasculature. But the conventional PDT has got its own problems of choriocapillary atrophy and hypoperfusion, leading on to visual defects and long-term problems for the patients undergoing PDT for CSR patients. So because of these problems or side effects of PDT for conventional CSR patients, there are two methods that can be followed for safety enhancement. It can be either the half dosing of the PDT, or it can be half fluence. Half dosing is, instead of 6 milligrams, we give the 3 milligram per meter square body surface area of viscidine. Or it can be the half fluence, that's the exposure of the laser. Instead of 50 joules, you give a 25 joule exposure of PDT. So you can either have the half dose or the half fluence PDT. Histopathologically, Bruch's membrane was intact in all the patients. When you are comparing a 50 joule with a 100 joule exposure, the overlying photoreceptor layer as well as the other retinal layers, including the retinal capillaries, were well preserved. Bruch's membrane was intact, and despite a choriocapillary occlusion, the photoreceptor inner and outer segments, or the IS-OS junction, did not show any signs of regeneration. This is a patient with CSR who underwent PDT. This is the pre-treatment multifocal. You can see a little bit of suppression of the amplitude of the waves within the central area. And 4 days after the PDT laser, immediately the foveal spike is seen. And 1 month after the PDT, you can see a good normal spike of the multifocal ERG with normal wave pattern coming back as compared to the pre-PDT CSR. Coming to the poor prognostic factors, old age is one of the poor prognostic factors if the age is more than 55 years. Intrinsically, it's because it's less healthy RP in the elderly, or the coexistence of early but undetectable diseases such as AMD. PED is the next prognostic factor. Most severe pre-existing RP damage in patients with PED has been noted, less effective laser penetration, and higher PDT toxicity at the RP layer in cases with PED. And the third entity is subretinal fibrin. Verteporfin has a higher affinity to the fibrin and leads to an exaggerated response to PDT, causing RP atrophy and long-term choroidal ischemia. Complications of PDT, it can produce transient visual disturbances, injection site adverse events, transient photosensitivity reactions on the skin, and infusion-related low back pain or chest pain. However, most of these events were mild to moderate and resolved spontaneously. You have to tailor the therapy to obtain the maximal treatment effect with minimal toxicity in treating patients with CSR, since they usually have a relatively good baseline visual acuity. We had done a study in our center. We had done a prospective non-randomized case control study. 20 eyes were treated with low fluence PDT. Severe cases of CSR with exudative detachment, subfoveal fibrin, PED, diffuse retinal pigment epitheliopathy or sick RPE syndrome were included. Inclusion criteria was a persistence of detachment more than 6 months, single or multiple subfoveal leaks, neurosensory detachment of the macula, and presence of choroidal hyperpermeability on ICG. Exclusion criteria were macular diseases other than the criteria mentioned above and vascular or non-vascular retinopathy that might have adversely affected the macula. Treatment was performed only after obtaining the informed consent. Patients were assessed at baseline and follow-up examinations were scheduled at monthly for 3 months and 3 monthly thereafter. Baseline visual acuity, slit lamp examination, applanation tonometry, fundus examination with indirect as well as a biomicroscopic evaluation was done. OCT was performed for each patient at every visit. Fluorescent angiogram and ICG were optional but were done compulsorily at baseline and at 6 months post-treatment. Reduced fluence PDT was done with a 6 milligram infusion of butyporphin over 10 minutes, followed by a delivery of diode laser at 689 nanometers 15 minutes after the start of infusion. But the dosage of laser was reduced to 25 instead of the 50 joules, and a light dose ratio of 300 millivolts per centimeter square, and photosensitization by a laser was done for 83 seconds. So we followed a method that is reduced fluence PDT rather than the half dose PDT. In both treatments, spot size were determined by measuring the area of active angiographic leakage in the middle phase of the angiogram. The baseline criteria, 20 patients, 19 males and 1 female. Mean duration of the serous detachment was 21.5 plus or minus 17.39 months. The baseline characteristics, all the patients had subretinal fluid. 85% of the patients had PED, 15% of the patients had fibrin, 40% of the patients had cystoid spaces, 15% of the patients had exudative detachment, and there was no RPE rip noted. The FFA characteristics as baseline was a diffuse ooze in 55% of the patients, diffuse ooze plus a leaking PED in 5%, subfoveal ink blot in 15%, and subfoveal leaking PED in 25% of the patients. The mean central macular thickness pre-treatment was 362 microns, and post-treatment after the reduced fluence PDT was 209 microns. And the final outcome, there was 15% of the patients that showed a persistence of fluid after the treatment, but 85% of the patients resolved with one treatment. Visual outcome also showed a similar improvement in vision, pre-treatment and post-treatment. Post-treatment OCT features included subretinal fluid, PED, fibrin, cystoid spaces, RPE degeneration, foveal thinning, and exudative detachment. The mean duration of resolution following treatment was 5.5 weeks, and the mean number of sittings of reduced fluence PDT was 1.05. Ribaldi et al. Compared the efficacy of full fluence PDT to half fluence PDT for chronic CSR in a prospective non-randomized trial, and he noted a complete resolution in 79% of the patients in the full fluence group and 91% of the patients in the half fluence group. Our results are similar, with 85% of patients showing a complete resolution of CSR and 68% of the patients showing a 2-line improvement. Half fluence PDT can achieve comparable, if not superior, outcomes to standard fluence PDT while decreasing the risk of adverse side effects of standard fluence PDT, such as choroidal neovascular membrane formation and long-term choroidal hypoperfusion. Thank you.